Hey class, Dr. Dorf with a lecture on COPD. Now for COPD, this is guideline based in terms of diagnosis and treatment, as most everything you're starting to find is as you're doing your readings. Guidelines that we refer to for COPD are called the GOLD guidelines. Comes from the Global Initiative for Obstructive Lung Disease. That's where the GOLD acronym comes from. There's an updated 2017 manual for the treatment of COPD that was released by the Institute. So you can check those out. You can download them, or if you're using UpToDate, as I have strongly recommended throughout the semester, you will find those. We'll cover them as well throughout the course of this lecture. So basically, what is COPD defined as? Well, the Global Initiative defines COPD basically as a common, preventable, and treatable disease. So three characteristics of COPD that you need to be aware of is that it's common, it's preventable, and it's treatable. It's persistent respiratory symptoms that allow or that cause airflow limitation due to airway abnormalities, usually caused by exposure to noxious particles or gases. We'll talk more about what that means in just a minute. Not always is it tied to smoking. Majority of the time, though, yes, it is. And then, of course, this leads to chronic airflow limitation, which is the hallmark of COPD, caused by a mixture of a small airway disease and parenchymal destruction, otherwise known as emphysema, and it varies from person to person. Chronic inflammation is, of course, an underlying theme. We talked about that already with asthma. It causes structural changes, narrowing of the small airways, and destruction of the lung parenchyma. A loss of a small airways may contribute to airflow limitation, which is a characteristic feature of the disease. That's a mouthful, but COPD is complicated, so there we go. Also, underneath the umbrella of COPD, you have chronic bronchitis, and we have emphysema, which both were kind of touched upon in the definition of COPD. So without getting into too much detail, difference between chronic bronchitis and emphysema. Chronic bronchitis is defined as a chronic productive cough for 3 months. So productive cough for 3 months in each of 2 successive years. So basically for 2 years in a row. And in a patient whom you've been able to rule out other causes of chronic cough, such as GERD or bronchiectasis or anything else. So that's chronic bronchitis. So productive cough for 3 months for at least 2 years in a row in patients where you've ruled out other causes of chronic cough. Emphysema, it's more of a pathological term that really describes some of the structural changes that are associated with COPD. Emphysema basically lives in the air spaces distal to the terminal bronchioles, otherwise known as the alveoli, right? So you're dealing with alveolar destruction. So that's really a hallmark of emphysema. Alveolar destruction caused by structural changes. Lungs are very elastic. They have collagen in them. So literally are elastic. We'll talk more about that in a minute. And that's kind of what leads to the severe obstruction in patients that have emphysema. They're going to have a significant airflow obstruction, which leads to the O in COPD. So I just wanted to touch on that just momentarily. So basically, if we're talking about the airways in these two settings, you're going to be having chronic inflammation. There's going to be hyperplasia of mucus, increased mucus production, obviously, right? Lots of secretions. Again, that's why we give anticholinergics. We've talked about that already. I'm not going to hold you responsible for knowing the different sorts of cells that are mobilized in COPD and actually cause inflammation of the airways. You guys have already covered that in patho. And then like I said, emphysema, that's going to affect, it's going to cause alveolar destruction. That's going to occur, by the way, in the, you've heard me talk about this already, but I'll put it out here, the parenchyma of the lungs. So that's where that occurs. And like I said, it's in the terminal bronchial, the alveolar sacs, and the alveoli themselves. Those get smaller as they get destroyed, obviously, which causes less surface area within the lungs, and that causes an expansion of air trapping. And that's why on X-ray you see all of this air trapping in someone with COPD. You'll see these hyperinflated apices, flattened diaphragms, and lots of air trapping, and that's really why. So anyway, we've covered that. Let's talk a little bit about the pathophysiology of COPD. So when we're talking about COPD and pathophysiology, the majority of it is going to be caused by smoking. In fact, I would say 99%, although I wouldn't. Evidence-based practice has shown that it's 99% of the cases are smoking. Not just smokers, mind you. So this can also be people who have been exposed to secondhand smoke. There's also data that shows that people who live in an urban environment are at a 25% increased risk of developing COPD. Reason for that is going to be pollutants and particulates in the air. So imagine living in Los Angeles with all of that smog. You may not have picked up a pack of Marlboros one day in your life, and you could very well have symptoms and the chest x-ray of somebody who has a 30-pack year smoking habit and wouldn't be able to tell the two apart from each other. And then there is a very small portion of the population that has what we call, it's supposed to be alpha. That was really ugly. Again, I'm showing off my third grade writing skills. Alpha-1 antitrypsin deficiency. That's going to be about 1% of the population. So as we talked about already, this leads to breakdown of elastic fibers, collagen, which lines our lungs and our airways. So you're going to be having elastic fiber breakdown, structural damage in the alveoli, the alveolar spaces, destruction under emphysema, we've talked about before. And as I mentioned, that destruction is going to cause a decrease in the surface area. I just lost my pen. There we go. Loss in the surface area in the alveoli. And that's going to mean that oxygen is going to have a hard time of escaping to get back into the bronchioles, and that's what causes your decrease in O2 levels in patients that have COPD. Other thing that it's going to cause an increase in what we call total lung capacity. So if you think about that, that's kind of what causes the hyperinflation that I mentioned before that we see commonly on chest x-rays, on plain films in COPDers. It's also what gives that barrel-chested wall appearance in COPD. And then finally, we're going to have narrowing of the bronchioles. If you Go back to your pathophysiology. The bronchioles are, of course, sitting above the alveoli. So you have narrowing of the bronchioles. Those are the main airways. Think of your main bronchus, right? Your main stems. I'm not going to dare try to draw those because that's just going to be horrible. But you're going to have a narrowing of the bronchioles. And that's going to lead to obstruction. So that's just some of the patho involved with COPD. So how are we going to diagnose COPD? Well, first off, we have what? We've been teaching this since assessment class. We have subjective and we have objective data. So our subjective, we have our history, right? So we're going to talk about risk factors. So make sure that you get a good history. And under that, you want to assess risk factors. I keep doing that to my pen. Sorry, guys. So risk factors. So family history, smoking history. If they're a smoker, what age were they when they started smoking? How much do they smoke a day? If they're a former smoker, date when they stopped, calculate out their pack year history. Environmental history, we talked about that before. Asthma can certainly play a role. So we're going to look at that. Then you're going to look at symptoms. The main symptoms you're going to be focusing on are going to be dyspnea, cough. I'm going to put sputum with that because that certainly plays a role. Wheezing, although we can have a variety of respiratory illnesses. Asthma, which we've already discussed. So with dyspnea, you're going to be asking about the amount of effort that's required to induce uncomfortable breathing. Most of these patients are going to deny true symptoms of dyspnea, so you have to frame it in a way that they can understand. So you're going to want to be trying to assess their activity levels because you'll find they'll have significant reduction in activity levels. I usually ask my patients, hey, how was the walk in here from the parking lot? Any issues with that? Do you feel like you just ran the Boston Marathon? A lot of times you can tell by watching them sitting right in front of you. You can look at them and see their pattern of breathing. But so that's one thing that you're looking at. Another thing with cough, with or without sputum production, but we typically see an increase in the amount of sputum production in these patients, especially during the times of acute exacerbations. Again, talked about earlier up top how there's a lot of mucus production in the setting of chronic bronchitis. So it's going to be a wet cough. Wheezing, again, you can have that with asthma, but typically you're going to find that wheezing occurs in COPDers during the expiratory phase. In fact, it's very prolonged during expiration. So keep that in mind. And then, of course, you're going to do your physical examination. And again, as you're getting history from these patients, you're watching them, you're assessing them, you're looking for any accessory muscle use, any central cyanosis. Are they having to stop every few seconds and catch their breath? Can they only get 2 or 3 words at a time? Are they able to make complete sentences? So again, you're looking at all of that. And the hallmark of COPD, and we touched on this a little bit during the asthma lecture, is we're going to be doing spirometry. So with COPD, again, we're going to talk about that FEV1 FVC ratio. And again, we talked about this with pulmonary function tests. You had this in diagnostics over the summer. So that FEV1 over that FVC ratio in COPD, if Someone is less than 0.70%, they have COPD. If they're above it, they don't. So basically, if you can get more air, or if you can get, sorry, if you can expel, if you can get out more than 70% of air within 1 second, then you don't have COPD. If you're unable to do that, then you have COPD. So that's what this represents right here when we're talking about that FEV1 to FVC ratio. FEV1 by itself also comes into play with the GOLD guidelines, which we'll talk about in a moment. So that kind of goes over pathophysiology and your assessment in COPD, with spirometry being the gold standard. So some key points so far, what we're going to look for when you're assessing and when you're assessing these symptoms. By the way, you may read in your literature different tools that are used to do so. Something called MMRC questionnaire or CAT questionnaire. I'm not going to hold you responsible for that, but that's basically what that's focusing on, is primarily on symptoms. There are tools specifically for COPD that are within the GOLD guidelines that speak to that. So, and since we're kind of talking about GOLD guidelines right now, let's go ahead and go over those, shall we? So, GOLD guidelines used to be you'd have 4 stages. That's kind of changed a little bit. Now they've come up with letters to go along with this as well. It's actually made it, in my mind, actually more complicated in terms of staging things. But anyway, your GOLD guidelines, this is in terms of classifying the severity of airflow obstruction in COPD. First thing you're going to get, and this is just what they used to be, was just FEV1 by itself, not the ratio that we just talked about, but FEV1 by itself. So you can be less than 0.7% on the ratio. That's FEV1 divided by FVC, but you're also able to measure FEV by itself, a predicted volume basically. So if someone was between 80 to 100, then they were considered Roman numeral 1. If they were 50 to 79, that's going to be 2, 30 to 49 was 3, 0 to 29. You're probably on a vent because you really aren't moving air all that well. That's 4. That used to be all that the GOLD guidelines contained in terms of classifying severity of airflow obstruction with COPD. Oh, they've added a few other things. Now they've added symptoms, which we just covered, and the different tools that can be utilized to assess symptoms. And then they're concerned about exacerbations. So with exacerbations, that's measured 0, 1, or more than 2 within a year. So now they've added, like I said, letters to all of this fun stuff. So this is kind of in a box. It's literally what it looks like if you look at the GOLD guidelines. You're able to download those for free, by the way. There's a pocket edition of GOLD guidelines that they used to send you for free. I think they charge you like $5 now if you want a laminated set of the pocket guidelines sent to you. sometimes you can find some of the pharmaceutical reps when you get back into the clinical setting. Those that hawk inhalers may have these for you. So anyway, over in this column, on this axis, this is going to be your FEV1. And down here in A, that's going to be our corresponding 1 and 2. Up in C, it's going to be 3. And then our folks who are probably on the vent on 4. Over on the other axis, over here on the right, you're going to have exacerbations. So up here, that's going to be 2 plus 1 and 0. And again, those are exacerbations. And then along the bottom, symptoms. That's terrific. Sorry guys, I have to take this call. I'm going to have to pause this lecture where we are at because that is a code red call out for SWAT team, which I serve as medical officer on, that I have to respond to right now. So I'm going to pause this lecture. I'll post part 2 after I get done with this. So I got to go grab my gear suit up and take off because we have a hostage situation, it looks like. So anyway, this will resume in part 2.